Okay, so today's lecture, I was asked by Dr. Cross that I should talk about big data in health. And this lecture is going to be talking about big data in health, but I'm going to focus specifically on some of the research that I'm currently performing, where I'm actually understanding the different biases that exist in big data for health. And so that's why I have entitled today's presentation Equity, Diversity and Inclusion in Big Data for Health. So a lot of what I'm going to be talking about is, it's healthcare. Everything is about healthcare. I just want to start by bringing your attention to this particular graph, whereby in terms of how much the data volume is increasing annually from 2018 to 2025. Let's see if I can have the pointer. Where is the pointer? Yeah, here. So actually, healthcare seems to be the sector within the economy that is growing in terms of data volume the most. And so what this means is that the future of healthcare revolves around big data, and particularly on, I'm sure you heard of this notion of personalized medicine, which is really the usage of big data so that we have much more targeted diagnosis and treatment. And it's also this sort of tendency to begin to treat patients before symptoms arise. So more on the preventative rather than the sort of curing aspect of health. And so by having all of this huge amount of big data, then we can have a very lofty goal, which is to be able to provide the right drug to the right patient at the right time and the right dose. With diagnostics which are low cost, fast, accurate, less invasive, and then a type of medicine that is what we call 4P, participatory, preventative, personalized, and predictive. So this is the sort of holy grail of personalized medicine, which, as I say, is anchored on big data. And even more sort of anchored on big data really is it revolves around the fact that we now have a human genome map, which allow us to genetically being able to identify and locate every single function that we know for the cell. And by understanding the interactions between the different genes, for instance, that we now have the map for, we can have a level of resolution for understanding of medicine at the molecular level. So if we think about why the genome and genetics is so important, is because every disease that you can think of now has a contribution from genetics. And so this contribution, we can measure it using big data sets that come from the study of the DNA of the patient, although this is not the only type that exists in terms of big data for understanding disease. However, the genetic contribution to disease, we now can measure it to an extent that it wasn't possible. And we have here two types of common diseases. So one of them is type 1 diabetes. And we can see that actually the contribution of genetics in the development of the disease is is actually much greater than the environment, which you can see the environment is here in kind of orange, and then the contribution to the development of the disease is represented as blue. And so we have type 1 diabetes, which is a disease, a complex disease, common disease that is mostly the consequence of the genetics that you have. Whereas melanoma, which is a type of skin cancer, we can see that the contribution to the development of the disease is mostly environmental, although genetics has a significant part as well, but not as much as environmental. So within this context of the fact that through quantifying the genetic contributions, which, as I said, they're based on big data sets, we can have a lot more predictive and descriptive models for the diseases that we are working with. So there is something called genome-wide association studies, which is a type of analysis that allow us to identify within the millions of different variants that any patient may have, which of these, if any, are actually contributing to the development of a particular disease. So here is a theoretical representation of how this technology works, which I'm going to repeat: genome-wide association studies. In order for us to be able to identify whether any given genetic mutation is actually contributing to a disease, the experimental design for this type of models is whereby we have a group of cases and a group of controls. They are all matched. Let's say, for instance, women with breast cancer versus women who have not developed breast cancer. And if we are able to find, like in this case, a particular variant, you have it shown here in red, that is more present, significantly more present in cases than in controls, in all equal conditions except that one, then we can statistically associate that perhaps, or most likely, this variant, which is more frequent in cases than in controls, is associated to the presence of breast cancer or that particular disease. So again, this is using huge amount, millions of data points. Here I'm just schematically representing this, and using computational infrastructure and statistical models so that we can infer associations between many small contributions that are the consequence of existing variants in our cases versus the controls. So there are big repositories of this kind of models, data-centric models. One of them is called the GWAS catalog, which contains the sort of central repository of all studies for genetic associations using genome-wide association studies for any given trait or phenotype. And so you can have a look at this. It's available from the European Bioinformatics Institute. And what happens is that if we then look at these models, the models that are being used, which really help us characterize and understand disease, they're mostly based on European patients. And here is the sort of important, the sort of kit or where this presentation hinges, is the fact that I'm just presenting one example of many, and I'm going to present some more examples. The current representation that we have for big data sets that explain our understanding of diseases, like this one for genome-wide association studies, are mostly based on data from European patients. And basically what this means is that the models that we have for understanding disease are mostly based on people of European origin or ancestral origin. And that means that the models perform much more accurately in representing the genetic risk for developing any specific variant, any specific phenotype or illness. They perform much better in those individuals for which they have been trained. And then we find that in a very important study that was published in 2016 in Nature, it was able to measure the ancestry of all of the individuals for genome-wide association studies deposited in the GWAS catalog. And they found that 96% of all individuals that have been used for all of the, in this case, 35 million samples and 2,411 genome-wide association studies, they found that 81% in 2016 are based on individuals of European ancestry. And so what this means is that those models, as I said earlier, are not going to be as precise for representing genetic risk if you apply to non-European individuals. So put it another way, this was another publication that came out last year. If we compare the ancestry of the individuals in this particular repository, the GWAS catalog, and the actual share of the global population, we have that for Europeans, we have approximately, let's say, 1.3 billion European ancestry people, whereas around 85%, something like that, of all of the data that we have is actually European. So as you can see in this graph, all of the big data that we have representing genomic data sets are actually based on a small segment of the population. And this has tremendous implications in the understanding of disease and our ability to apply these models for all of the different populations that we have in the world. So as of today, actually the numbers are getting worse. Instead of getting better, it's actually getting worse. So I took this picture in January, where we can actually measure the diversity, i.e. the ancestry of the individuals for which genetic models like this have been developed. And the vast majority, 94%, almost 95% of all of the individuals used to develop genome-wide association studies have been of European ancestry. And only a little bit Asian, and then tiny bit African American, Hispanic, and or other. So you can see really South America, Africa, and Central Asia, and Oceania, that they're completely empty. And this is bad news for our understanding of health and disease, because if the data that we have only represents a small percentage of the population, okay, we have a very interesting question from Megan. Is that due to who volunteers? Actually, I'm gonna say that later on, but it has to do with where the studies are performed and who's got the money to perform those studies. And in fact, around 75% of all of the data that has been produced for these types of analysis, it has been produced, privilege-based. It has been produced mostly in 3 countries, US, UK, and Iceland. So we learned about this bias that we have in our understanding of the genetics of complex diseases, which are the most common diseases like the ones I've shown. And as of June 2021, the vast majority of studies had been Europeans. And we would have expected that, as in 2016, this study that came out in Nature that I pointed out earlier, that, at that point, big agencies such as the Wellcome Trust and the NIH, they started, promoting the fact that we needed to have more diversity in our data sets. But what has happened is that from 2016 to 2021, actually, the proportion of samples from underrepresented populations have either stagnated or even decreased. So even though we've known about this problem at least for a decade, actually things are getting worse than getting better. And let me just give you some understanding as to why we should care about that. Because obviously we know that one thing is to know that data sets are biased. Another thing is to answer the question, so what? Okay, so we know that data sets are biased, but actually, why should we care about that? And the reason why everyone should care about that, both represented as well as underrepresented populations, is that the diversity in representation is essential so that we can really understand what's truly causing disease. Because by looking just at one type of ancestry data, a lot of that ancestry data that we use may have some of that may have noise, which we can confound. We can think that is causative, whereas actually, because we don't have a lot of sort of diverse data, that model that we have is actually not representing the complete picture of whatever it is that genetic markers which are contributing to the disease. So in other words, to be able to have the most diverse possible type of representation for genetic models allow us to have more accurate genetic models for all, regardless of whether they are represented or underrepresented. And that means also that the models that we are developing actually are not just applicable to one segment of one particular population. Because by having more diversity, we then have more accuracy and applicability of the information. And we can't understand, we cannot understand personalized medicine excluding of the benefits of these advancements to many populations. So that's not what personalized medicine is about. However, I'm talking about big data here, and I've just given you one example in genomics, which is genome-wide association studies. But this type of underrepresentation, as part of my research, which has been what I've been working on for the past year, really, we find that this underrepresentation is systemic to not just one specific type of data set, but many different types of data sets. So here I'm giving you another example. So you may have heard of pharmacogenomics. So pharmacogenomics is the understanding of how the genome or genetics affects our ability to metabolize drugs. And depending on the variants that you have in the metabolizing genes, most of them are part of what we call the cytochrome. So there are a number of enzymes that are involved in metabolizing the drugs as you take them. And depending on the variants and depending on the genetic code on that on those genes, you're going to have different dosages, optimal dosages. Depending on the genetics of those particular genes, you're going to have different needs regarding how much intake of a particular drug you should have. For instance, pharmgkb, which, as I said, is the repository of existing gene drug reactions. So the same as the GWAS catalog is the repository of genome-wide association studies, pharmgkb is the repository of existing data, pharmacogenomic data. And they basically grouped the different regions of the world into the different types of natives. So obviously, in North America, you're going to have a lot of people that would be of European ancestry. So we still will consider those people European ancestry, okay? And here what we are looking is the sort of natives, right? So we have Native Americans, we have East Asians, we have Europeans, we have Central South Asians, Near Eastern, also including North Africa, Oceanian. Again, in Australia, we will have a lot of people of European ancestry, so we don't count those. And then Sub-Saharan African and Afro-American and Afro-Caribbean and Latinos. So if we then quantify how much data exists in the repository in pharmgkb for each of these ancestries, we actually find that 64% of all existing data has been trained using European. And then around, if I remember correctly, it's about nearly 20% have been trained using East Asian, which are mainly, Japan, China, and Taiwan, perhaps. And then for the rest of the world, we have very, very tiny. And in fact, for Oceanians, we have nothing, okay, in pharmgkb. So here, what you can see is the degree of under or overrepresentation that we have in genomics, sorry, in pharmacogenomics datasets. So we have some peculiar numbers here because basically 0 would mean that the amount of data that exists is proportional to the share of global population that exists for that particular biogeographical region. So how this works, we said that, Americans, indigenous Americans, there are probably around 25 million people, and there's nothing. So you would need a small amount of Americans, Native Americans, to be able to have a proportion of pharmacogenomics data, which is similar to the existing proportion of pharmacogenomic data that exists in total. So if the so we say 0 here is the proportional representation of existing pharmacogenomics data versus the total share of the global population. And so you can see basically that Europeans are overrepresented. East Asians are a little bit overrepresented. And the most underrepresented population that we have is Central and South Asian. So basically, mostly people from the Indian subcontinent. If I understand correctly, around 2% of all existing pharmacogenomic data comes from people of Central South Asian origin, but they are around 2 billion people. So that's why they have the greatest deficit in terms of balanced representation of this biogeographical region in pharmacogenomics, even though there is more data for Central and South Asians than there is for Oceanians. But since so not Native Americans, and even Oceanians. But since there are a lot fewer Native Americans and Oceanians, then that's why this representation shows less deficit. But of course, we still need this kind of representation. The second most underrepresented in terms of their share of global population are sub-Saharan, then Latinos. This is quite curious that African American and Afro-Caribbean are a bit more represented than their share. I think that because, as I said, a lot of the analysis are performed in the US. So sometimes in the US, they take African Americans as a proxy for sub-Saharan, but it's not very good in terms of their sort of equivalence, because African Americans, they contain on average around 20%. They are mixed 20% with Europeans. Okay, and then if we look at the clinical trials between 2015 and 2019, reported by the FDA, which is the agency that basically approves the drugs that are being developed, we still see that 76% of all clinical trials for all drugs are actually performing European. And then a little bit in Asian, a little bit African or African American, and then Latino, for instance. There's even no information about Latinos. So the genetic variability in genes encoding drug metabolizing enzymes, as I said earlier, contribute to the high numbers of adverse drug reactions reported in Africa. So here you have this gene, which is called CYP2D6. This gene is actually one of the cytochromes. It's actually the most important gene in terms of percentage of prescribed drugs that are metabolized by this gene. So 25% of all prescribed drugs are metabolized by this gene, CYP2D6. And if we actually look by the same biogeographical regions, the proportion of individuals within the different regions that are either ultra rapid metabolizer or poor metabolizer or indeterminate metabolizer, we start looking at important differences. I want to draw your attention to Oceanians. So Oceanians, they have a percentage, around 18% of all of them are ultra rapid metabolizer. If you give, for instance, codeine, which is, I'm sure you might have heard of that drug, is prescribed as a sort of analgesic. And so if you prescribe codeine to Oceanians, you need to know that actually around 20% of all Oceanians are ultra rapid metabolizers. What that means is that if you give them the normal dose, they can actually have an overdose, because the ultra rapid metabolizers, they metabolize the codeine too fast into morphine, which is the active component that codeine has. And so you might end up having an overdose of morphine just by giving the normal dosage of codeine, and that could lead even to death, respiratory arrest, for instance, and so on. So it's very dangerous. And then another very important fact that we find that is about to be published is that we have a huge amount, around 35% of all of the variants that we have known for this particular gene. In Africans, we have no understanding of what effect those variants have. And so this is because we think there is a lack of data that will tell us some data that we've observed in Africans, but we don't observe anywhere else. And because we haven't had the opportunity to really test it, we are unable to assign what they mean in terms of the metabolization status for this drug, and that basically for this gene, and that basically means that we're going to be a lot less accurate when we prescribe drugs involving this gene in terms of the appropriate dosage if we are treating sub-Saharan Africans. Let me give you some examples. So, as I said, CYP2D6 metabolizes around 25% of registered drugs, and one of them is coding. So I mentioned that there's, sub-Saharan Africans are most affected by adverse drug reactions than the rest of the world. And here we have an example. Around 30% of Ethiopians have a mutation that increases the adverse drug outcomes dramatically. And so because 30% of Ethiopians have that mutation, then the government decided that we're going to ban completely coding. And so coding is not prescribed in Ethiopia. And basically, this a very common drug that, because of the genetic understanding that we have, is very poor for this particular population, then they are unable to benefit from the appropriate administration as some others would do. There are also another example, for instance, in patients with breast cancer who are treated with tamoxifen in some African populations, make them unable to respond appropriately to this particular drug, and which is also metabolized by CYP2D6. So and the list is continues. So if we have individuals who are poor metabolizers, around 5 to 10% of patients in Europeans are poor metabolizers. That means that you need to give them more drug for them to actually respond to the appropriate level. So that's not as bad as, having morphine toxicity like you could have if you're an ultra rapid metabolizer. Which, as I said, around 28% of North Africans, Ethiopians, and Arabs are ultra rapid metabolizers. And so we know that this exists, and yet the prescription that we have is mostly around our understanding of the genetics in Europeans. Another drug, which is called warfarin, is the leading drug for cardiovascular disease worldwide, and yet is among the top 4 drugs leading to hospitalization from adverse drug reactions in Africa. And also we know that this is a very important source of adverse drug reactions in the rest of the African continent. The problem with warfarin is that most individuals studied of African ancestry involve ancestry conducted in the US and Brazil, which have, as I said, a significant degree of mixture with Europeans. And that means that many of the results that we have from African Americans are not so well transferable to sub-Saharan Africans. An example of how this is limiting our ability to treat non-Europeans. So there is an algorithm that is able to predict, based on your genetics, the risk of over anticoagulation. I mean, over anticoagulation is really bad because you basically may bleed to death if you have the wrong dosage. And we can actually predict that risk very accurately in about 18 to 24% of Europeans. But Europeans are the only ones that exclusively benefit from this prediction of over anticoagulation. Other genetic ancestries, biogeographical regions, don't have that particular dosage algorithm, and therefore they do not benefit from our ability to predict over anticoagulation. And that's precisely one of the reasons why warfarin is so prevalent in terms of cause for hospitalization from adverse drug reactions. There's also our ability to predict diseases, risk of diseases. There's something called the UK Biobank, you may have heard of. The UK Biobank is basically 500,000 individuals, most of them quote unquote white British, around 400,000 of them, that is being used as the validation for genetic susceptibility risks. And we have, as I said, models that are able to predict illnesses using the UK Biobank as the sort of validation case. And what we found is, what Martin et al. In Nature Genetics found is that if we use existing prediction models for complex diseases from the UK Biobank, we find that those models are best, most accurate for Europeans. And the further in terms of genetic distance you go from Europeans, the less prediction accuracy existing genetic models for prediction of risk are going to become. The worst of are the Africans. So models of genetic risk prediction for Africans are the least accurate. And this is obviously, again, another point for issues in the fact that the data that we have is biased, and this is affecting it's a question of justice, and it's a question of data equity. How can we change it? We'll talk about that a bit further away. Can I suggest that we hopefully in a few slides I'll be able to answer that. It's not an easy thing, but at least, you know, we can. I'll just say for now that at least the first thing with which we can do at the moment is really to raise awareness of the fact that these underrepresentation issues are actually costing lives, and it's having an important price for people to pay. So, and that's what, you know, if we're able to raise awareness, not just among the research agencies, but, you know, in the general public, at least we're beginning to you know, the first step in addressing this problem is to raise awareness. Okay, but there are other things that we can do. But I just want to say that underrepresentation is not just on the ancestry. There's also underrepresentation in gender and sex in existing data sets. In a publication that just came out, which I led, we basically said that there is sex bias in pharmacogenomics datasets. We know that women experience adverse drug reactions nearly twice as often as men, yet the roles of gender and sex as biological and social factors that may increase the risk of adverse drug reactions are poorly understood. And because women have greater life expectancy in many regions of the world, they often have a higher proportion of the elderly population that are likely to require polypharmacy. So polypharmacy is that you basically have to take more than one drug at the same time. And these polypharmacy regimens can lead to health risks and increased healthcare burden. So another thing that we mentioned is that most drugs withdrawn from the market increase health risks for women, which is consistent with a poor representation of women in clinical trials. And we have that women represent only 38% of participants in drug efficacy and pharmacokinetic studies. For instance, we found that in 192 clinical trials of individuals with chronic kidney disease, only 45% of the participants were women, whereas women are 33% more likely than men to suffer from chronic kidney disease. So here is an example where lack of representation or lack of balance representation is actually having an impact. Because again, if the data that you have is sort of biased towards one particular type of segment, then it's bound to represent or be more accurate for that segment compared to the other, or even it may actually not give you the best, most accurate answer. So we have other examples which I'm not going to go into because they're a bit complicated, but also there is underrepresentation, for instance, in my field, in the genomics workforce. So we have seen that genomics is important in terms of our understanding of diseases. And we performed an analysis of one institution, one important international initiative, which is the Global Alliance for Genomics and Health. So the Global Alliance for Genomics and Health encompasses the top institutions around the world that are performing clinical genetics investigations, okay? And I form part of the Equity, Diversity and Inclusion Advisory Committee. And as part of the research that we perform within the Global Alliance for Genomics and Health, which encompasses around 1,000 institutions from around the world, we found that most people who are researchers working in or involved in the Global Alliance for Genomics and Health are male. So there is an underrepresentation of females in people working in genomics, basically. But also, there is underrepresentation in terms of what countries are represented. So here we have the Anglosphere, which is Canada, US, British Isles, New Zealand, and Australia. We found that most people contributing to the Global Alliance for Genomics and Health are in core Anglo countries. So not just the sex underrepresentation, is also the regions of the world that are represented here. And there's also underrepresentation in who is actually accessing direct-to-consumer genetic tests. So you may have heard of this thing called ancestry.com or 23andMe or myheritage.com. They are genetic tests that you can buy on the internet. They send you a test tube, you spit on it, and then they give you information about your ancestry. And very, very limited, but at least some, if any, health data. So we actually analyzed existing data from 23andMe that has been made through a variety of initiatives where people basically, you can download your data and share it with the rest of the world if you want. So we scouted the internet and we found a number of repositories that contained people who had done their genetic testing and had decided to share their data. And because genetics can basically be used to infer your ancestry, we used something called the 1,000 Genomes Project that contains people from 28 different population groups. We classified those groups into three main continents: African, European, and Asian. And so by extrapolating the genetic distances that we have from the reference datasets from the 1000 Genomes project, we then were able to extrapolate from existing data openly accessible for people who have shared their genetic testing data, where they come from. And we found that 95% of all the data for people who have performed and shared this data are European. Of course, this is obviously a very imperfect way to extrapolate who is accessing this type of genetic test, but at least assuming that there are no cultural values in terms of who is, more likely, if there is any biogeographical region where people are more likely to share, or if, any other type of biases. All things equal, we found that if we were to infer the ancestry of people who have access to these genomic data sets, to this genetic testing, the vast majority are European. And in fact, I could argue that the bias of people accessing these data sets is greater than the existing reference data sets. Because basically, what this all means is that our ability to stratify high-risk individuals for genetic contributions to disease in underrepresented populations is compromised. And the research studies that do include underrepresented populations, sometimes because there's such a small number of people from non-European background, for some studies, for some researchers, those small samples end up being disregarded due to the low statistical power that they have and their ability to contribute to our understanding of disease. And the biases that result in associated genetic and medical practices are that these interventions are mostly informed by and benefiting only a subset of individuals in the global population. So what is it that is stopping people from accessing the benefits of advancements in genomics and big data in general? Genomics being the tip of the iceberg, but not the only data source. Well, obviously, financial, lack of time and resources for meaningful engagement, social, political, structural, and language barriers, lack of awareness, an impression that this work is not designed for one's population, and lack for agreed standards and metrics on how to measure diversity, because it's a very, very difficult task to be able to know to be able to know what should we target to, what should be the right representation, and there are so many different types of classifications that we can have that actually this is very challenging. So coming back to what Gabriela was asking, what can we do to address this bias? So first of all, increase awareness, which is something that we are doing right now. So we need to educate health providers on the existence of ancestry and sex biases, and then also eliminate cultural biases. Of course, financial support, and avoid the discrimination of less well-resourced groups. And we have to have better standards for study design, where, the same as you do an ethics study requirement for any type of research that you do, where there should be some kind of minimum requirements for equity, diversity, and inclusion when testing patients. We also need to reduce technology biases, because as we know, most of what we know is based on European data, and therefore the genetic markers that we tend to test for are those that have been identified mostly in Europeans, which may not necessarily be applicable to other ancestries. And we also need to equalize the study design biases. So development of studies that include, for instance, pregnant women. We know that there's zero, for very obvious reasons, but there is zero data on pharmacogenomics in pregnant women, which is a lot of the, you have seen that for some drugs, they say pregnant women shouldn't take them, and it's probably because we have no data, and so we can't risk it. Okay. What else can we do? Well, we need to reduce the uncertainty in terms of technologies to adopt quality controls. That is, controls that are more representative. We have to include more diverse ancestral and sex datasets, and we need to reduce barriers to clinical adoption by providing relevant infrastructure, resources, training, and support. And of course, to increase transparency. We need to know, especially for international organizations such as the Global Alliance for Genomics and Health, we need to be able to know where we are at in terms of the representation. And we should demand that international organizations are able to publish the share of diversity that they have in their workforce, their trials, their experiments, the data. And of course, this is particularly critical now, because for sure you've noticed that we are in the in the age of artificial intelligence. And artificial intelligence is based on data. So unless we have more representative data sets, then all of these advancements that are occurring as a consequence of artificial intelligence, they're going to perpetuate and in fact expand the biases, simply because of the fact that the data they're based on is biased data. Okay, so that's why it's so important. I'm going now to summarize what we've learned with this research. What have we learned? Well, we all know that there are biases, but we don't know how to quantify all of them. And one of the things that I do believe is that the proportional representation, although it's a start in terms of the type of analysis that you can perform, is still not good enough, because there are some populations, such as Africa. Africa contains more diversity, genetic diversity, than the rest of the world combined. And it has something like 1,500 different languages, and I don't know how many cultures it has. So there's a lot of diversity in Africa that doesn't exist in other parts of the world, which are a lot more homogeneous. And we haven't even touched the topic that there are people with disabilities, deaf, blind, people with Down syndrome, and they are completely lacking in terms of their representation. And they have the right also to access this genetic information and have access to the advancements of science. We have no clear understanding of how these biases affect different diseases. We have some more diseases that are more prevalent in different world regions, and simply because they are not in the West, perhaps they are less well understood. And we don't know also how different genetic annotations, so all of the reference information that we know of, is relevant for different populations. I've also mentioned that South Asians are the least well represented proportionally, given that their background is more homogeneous than Africans. That probably means that still Africans are more likely to be disadvantaged because of the greater diversity that exists there. So we would need more data from Africans to be able to explain the same amount of diversity that we have for Indians, let's say. So there's also hardly any data on indigenous populations, such as those from Oceania, and then from Latin America, like people from Native Americans, for instance. I also think that it all seems to come down to money, as Megan as said earlier. Yeah, it's definitely privilege based, with poorer people having no access to genomics. Direct to consumer genetic testing, for instance, they only ship samples to North America and Western Europe. So if you are outside of that supply chain, which basically counts for pretty much all of Latin America and Africa, then you're not going to get access to this kind of genetic test. So in terms of conclusions, I've just talked about genomics because it's the type of big data sets that I'm most familiar with. But, this is probably applicable to pretty much every other type of data that we have out there. And it is important that the insights and benefits are available to everyone, irrespective of their ancestry, sex, religion, you name it. Quantifying global data underrepresentation is therefore a critical first step in our understanding the current stage of research and ensuring that what we find is actually applicable to all peoples. And failure to do so will lead to inequities in healthcare outcomes, which means that people who are not represented will suffer the consequences. I just want to finish today's presentation with the Article 15 of the International Covenant on Economic, Social and Cultural Rights, which was adopted by the United Nations in 1966, which recognizes the rights of everyone to enjoy the benefits of scientific progress, and hence, access to these advancements that we're having in genetics and in health data science in general. So with that, I'd like to say thank you for your attention. Here are some of the people I've been collaborating with. And if you had any further questions, I'm happy to answer them. Thank you for your attention. Oh, Sabini. Okay, guys. See you soon then.